Hello, our fellow laboratory scientists and honoured doctors. Thank you all for coming along for our monthly lab seminar case study presentation. Our focus for tonight is the antibiotics and diarrhea management. I'll briefly review the background information on the case study before we show you what our findings were. Our patient was 85 years old female who was transferred to the hospital from the nursing home after being treated for urine and blood infections, as she was developing copious diarrhea. And the samples collected for the investigations were her urine and stool. Interestingly, both of the samples had no cultures when we inoculated into standard agar for further studies.
The case results reveals no growth or isolates in blood and urine samples. The assumption is that the antibiotics used in the current case has already removed the original cause of illness and is now the primary cause of copious amounts of diarrhea. Generally, antibiotic-induced diarrhea is caused by Clostridium difficile, generally targeting the elderly aged 65 and above. Thus, we must find a methodology to assess, detect, and treat this antibiotic-induced diarrhea before it complicates, putting the patient's life at risk. Clostridium difficile is the primary cause of infectious diarrhea in relation to antibiotic use. It is fastidious, gram-positive, and spore-forming and causes pseudomembranous colitis, which refers to swelling or inflammation of the large intestine. Patients that are at high risk to C. difficile infection are generally elderly, hospitalized, or in care. These traits heavily relate to the case at hand. Clostridium difficile colitis in antibiotic therapy can cause major problems. Not only does it have a high mortality rate when left untreated, it is hard to detect and is infectious. If an antibiotic-treated patient ingests the bacteria, the organism is likely to proliferate drastically due to the patient's natural flora lowered by the antibiotic and C. difficile not having to compete for nutrients. If the ingested organism has a toxin production gene, it may escalate and cause colitis. Furthermore, with the organism becoming more resistant to antibiotics, the spread of C. difficile within patients and the healthcare providers reveals how easy it is to pass it on to other elderly or antibiotic-induced patients with impaired immune function, revealing how the infection prevalence can be high in hospitals and nursing homes. Thus, people that are being treated are at risk due to the incidence of C. difficile disease increasing and the strains becoming more virulent and resistant. The detection and prevention is important for our elderly and sick.
Referring back to the original sample, no pathogens were detected in the patient's stool. This negative result likely represents the absence of routinely tested for organisms: Salmonella, Shigella, Campylobacter, and some viruses. Clostridium difficile is not a part of routine testing on fecal samples, and so should have been requested for by the doctor or recent antibiotic use mentioned in the clinical notes. And so a new sample was taken for analysis. A variety of test types and methodology exist for the identification of Clostridium difficile. The golden standard for identification has been toxigenic cell culture with toxin neutralization assay. Additionally, a few selective and differential agars also exist for colony visualization. However, culturing is time-consuming, labor-intensive, and requires technical expertise. Nucleic acid amplification tests, such as PCR, can test for the DNA or RNA of Clostridium difficile. Recently, multiplex PCR panels have been introduced, which simultaneously screen for the common causes of diarrhea. However, sensitivity and selectivity vary with the panel chosen, and true negatives would need to be confirmed using another method, which would delay the results. Testing spores also tends to produce poor results. Today, almost all cases are identified by direct testing of the sample using non-culture methods in rapid biochemical tests. For our patient, this 2 to 3 step algorithm was chosen. Detection of GDH was used to initially screen the stool sample for the presence of Clostridium difficile. Positive samples are then further screened for toxigenic strains in an enzyme immunoassay. A positive result for GDH and toxins can be reported, or negative for a toxin may be confirmed using PCR methods. This method was chosen as it is cheaper and faster than culturing, and has a high sensitivity and specificity. Glutamate dehydrogenase is a highly abundant enzyme present in the cell wall of Clostridium difficile and so acts as a sensitive screen for its presence in a sample. Yet GDH is non-specific to toxigenic strains that cause colitis, and so a toxin test is required. Both GDH and toxins can be detected by qualitative immunoassay in a single test card. This method uses a lateral flow chromatographic immunoassay and provides a result in less than 10 minutes. As a diluted sample flows along the test strip, the analyte will bind to an antibody. A positive result is marked by a change in color in a specific location along the test strip. Most strains produce both toxins. However, if the detected strain is negative for toxin A, yet positive for toxin B, the result is still recorded as positive for infection, as it is still capable of causing disease.
Confirmation of isolated colonies is done by using PCR, marking TCDA, toxin A, TCDB, toxin B, and trirose phosphate isomerase genes, which are the main markers for C. difficile toxin production. Through the use of MagnaPure total nucleic acid isolation kit, the sample can be tested using a magnetic-based technology in tandem with PCR. Simply put, the sample is collected, refined with provided buffers, and run in a PCR machine, cloning the marked polymerized chains, thus revealing the markers tagged. In this case for TCDA, toxin A, TCDB, toxin B, and trirose phosphate isomerase genes. Another test for confirmation is the ELISA, an enzyme-linked immunoabsorbent assay using antibodies to bind with antigens and detecting their fluorescence, determining TCDA, toxin A, and TCDB, toxin B, based on their intensities. The protocol uses the CDAB automated enzyme fluorescent immunoassay. Once 200 microliters of specimen is prepared with diluent and centrifuge, supernatant is added, and the sample is processed by the CDAB machine. The results will show negative, equivocal.
What we were expecting our results to be were as follows. From the fresh stool sample taken, we performed the GDH test, which will come out as positive, and then the follow-up EIA to be positive as toxigenic strain. This would give us the conclusion that the patient was suffering from CDI. If further confirmatory tests were required, then we can also use the fresh stool sample to prepare the C. diff culture, the cycloserine cefoxetine fructose agar, or CCFA, for both AST and API-20A.
Other pathogens that may cause antibiotic-associated diarrhea include Staphylococcus aureus, Clostridium perfringens, Klebsiella oxytoca, and Salmonella. And so if the toxins and PCR panel were negative for Clostridium difficile, then differential agars would have been set up to further investigate the cause. Diagnosis relies on a positive fecal sample in combination with a patient's symptoms. Once diagnosed, the management of this patient may include supportive care, quarantining from other residents in the nursing home, and antibiotic therapy in non-self-limiting infections. Antibiotics may be used to treat high-risk patients to prevent complications or relapse. Antibiotic sensitivity testing is not routinely performed for Clostridium difficile. However, may include the following treatment options. Hypervirulent strains with multiple resistance mechanisms are common. Resistance to metronidazole and vancomycin pose problems for treatment.
And this is our treatment suggestions to the doctors who might be facing similar cases in the future. We first suggest that the patient withdraws from antibiotics such as cephalosporin and clindamycin. This will allow the unbalanced microbiome to be restored. Second is the prescription of vancomycin instead of metronidazole as first-line therapy if the CDI case is severe. This is so that there is less chance of treatment failure and for faster symptom resolution. There has been increased cases of CDI over the years, which is a big concern. This is because there are limitations in treating the patients, as well as growing bacterial resistance. Also, most of the antibiotics have associations with CDI. Obviously, further researches are being done as we speak in hopes to better treat the CDI. However, studies suggested that more aggressive preventative measures such as barriers, hospitals maintenance via the use of sporicidal agents for surface cleaning, and reducing contacts of the patients are best solution. Also, things are not looking too grim for our future, as more and more antimicrobials are in development, although further testings are needed. And that's all from us, and thank you all for listening.
Or positive results according to fluorescence intensity.